Type 2, there is a minimal cortical integrity maintained. Usually the posterior cortex will be in contact. Okay, how do we treat this? The treatment mainly will be manipulation, reduction, check the reduction in both planes, maintain it and cast it. Okay, if the reduction is not maintained, then directly go for pinning. Okay, so correcting the coronal angulation. How do we correct that? First thing, okay, to correct the coronal angulation, we do something called as pronation. Okay, and we have to re-establish the flexion fully. Okay, if the reduction is stable after doing these things, pronation and flexion, then if it is stable, then we can put a cast, and given there are no vascular compromises. Okay, we have to, how do we check for stability? We check it in both flexion and also in external rotation. Okay, doing that, we see that whether the fracture is stable or not. Okay, so Wilkins has again divided this this fracture into type 2A and type 2B based on the stability. 2A is stable, 2B there is some degree of rotation or translation. Okay, so how do we correct this type 2B? This is what I was talking about. The type 2B require close reduction and pinning for extra stability. Okay, so what are the most common complications that we face during pinning? So the pin can migrate, there can be an irritation, there can be an infection, and there can be an elbow stiffness. Okay, so these are the things. Next, type 3. Coming to the type 3, we have posterolateral and posteromedial types. The posterolateral has more complications. There is a brachial artery injury and also a median nerve injury, and posteromedial side ulnar nerve injury is more common. Okay, so the posterolateral type, it is difficult to reduce to, and there will be a soft tissue impingement. The most common soft tissue that gets impinged is brachialis muscle. Next, there is posteromedial type, that is radial nerve is most commonly involved in this. So post reduction, you can do lateral pinning or you can do cross pinning. Okay, so lateral pinning, usually the stability will be less than that of the cross pinning. So you can prefer cross pinning. So there are many studies that suggest either way, but cross pinning is commonly preferred. Okay, the median nerve is at medially ulnar nerve is at risk. So to pin from the medial side, it is better to take a small stab incision, identify the ulnar nerve, move the ulnar nerve, and then go with the pinning. Okay, so why to open in case of type 2 or type 3 fractures? Because the reduction will be very difficult, first thing. The second thing is there will be soft tissue impingements. Okay, the soft tissues need to be removed in order to reduce the fracture. Okay, the most common soft tissues impingements that occur here are nerves, periosteum and muscle. Okay, so next, how do we see the displaced type 3 supracondylar fracture with absent pulse? Okay, whether it is an adequate perfusion or pulseless extremity. If there is an adequate perfusion, reduce the fracture, see for the capillary refill and wait. Okay, do not hyperflex in this situation, because we might actually cause damage than saving the limb. Okay, so the second one is pulseless extremity. Reduce, pin it. If it becomes pink and pulseless, then you can wait. If it becomes complete, if it still remains dysvascular, then it's better to explore. Okay, consider fasciotomy, expose, and then also extract the graft in order to repair it. Okay, next we have type 4. Type 4, as I've already told you, it is completely unstable. There are no periosteal hinges. So how are we going to do? How are we going to fix the or hold the fragment? Here we pass pin from transolecranon, that is from the olecranon directly into the humerus, so as to hold the distal part of the fracture fragment. After that, we can perform cross pinning or lateral pinning. So we have finished talking regarding the supracondylar fracture and all the features, etc., clinical features, diagnosis, management, etc. So in this video, it's a very small video. We'll just talk about the images and radiological features, the signs, how they are seen, etc. Also, the first slide that I have put here is Gartland humeral classification. Okay, as I've told you, there are 4 types. Type 1 is an undisplaced fracture with a well-maintained alignment. Type 2, the alignment is displaced and there is a minimal displacement, there is posterior contact is maintained. Okay, type 3, the contact is lost but the periostal connection will be there. Type 4, the complete loss of periostal hinges, so then it is very difficult to manage. Okay, so that is the first slide. So the next slide, what I put here, this is called as pucker sign. Okay, the pucker sign happens when the muscle tissue gets impinges within the fracture site. Okay, the proximal part of the fracture fragment will go and puncture over the muscle. Okay, the most common muscle is brachialis muscle. Okay, so this is how it looks. So coming to the next the lines. The first thing is anterior humeral line, which tells us about the alignment. Okay, normally the anterior humeral line, when seen on the lateral X-ray, it cuts the capitulum. So if it doesn't cut, then it means that there is a supracondylar fracture. Okay, so these are the examples how the supracondylar fracture can look. Next, this slide tells us regarding the crescent sign. So the overlapping part of the capitulum over the olecranon is the crescent sign. Okay, this crescent sign suggests that there might be an varus malalignment. Okay, that means there might be an medial column collapse. Okay, so these are the examples regarding the fat pad signs. What are these fat pad signs? That means that the fat has displaced posteriorly or anteriorly during these fractures. Okay, so that is the posterior fat sign. This is the anterior fat pad sign. Okay, so this is how we treat. The bigger picture what you are seeing is called as lateral pinning. So the smaller picture what you are seeing is called as cross pinning. Okay, there are still many more methods to come. Okay, but most common practice